Hello, everyone. My name is Gabriel Altit. I'm one of the neonatologists based at the Montreal Children's Hospital. And this will be one of the modules for teaching purposes or educational purposes done by my laboratory, the Neocardio Lab. So everything that I will outline on this workshop today and video is something that is free of use on internet, and we'll be using some of the material outlined on the website at www.neocardiolab.com. And really the purpose of these videos and workshops are to provide support whenever trying to learn or better understand images that are acquired in the context of neonatal echocardiography. This is not meant to be reference, and so a disclaimer would be that you should always go back and evaluate with your local experts, as well as reference textbook and literature whenever evaluating images acquired in the context of clinical context. So there is a breadth of images being done in the context of neonatal care. And hopefully some of these workshops will allow you to have a critical eye when looking at some of these images being acquired in the clinical context. Today, we will be looking first at the parasternal long axis view. And we'll be talking about some of the principles outlined on this view. And then hopefully in other workshop, we'll be able to discuss some of the images that are acquired in other views. So I will share my screen to show you where I'm obtaining some of the images that are available on the net. On the website of the neocardiolab.com. So you can see that on the website, there's a section named Targeted Neonatal Echo. And within the Targeted Neonatal Echo section, we will be going to look at the parasternal long axis view, which is this first button here, which can be also obtained by just clicking here. So we will outline some of the basic and regular views that we have in the context of normal newborn cardiac ultrasound. Here on this first view that you can see here, we have the long axis of the cardiac structures with an en-phase view of your aortic valve, your mitral valve, your left ventricle, and your right ventricle. And then here we can see part of the right ventricular outflow tract. So in this view, it's already a good view to be able to observe the contraction of your left ventricle. You can already have a sense of your left atrium, your descending aorta, the mitral valve as it opens and closes. As you know, it opens in diastole for the filling of the left ventricle and closes in systole when it ejects into the LV outflow tract. You can see that you have your two leaflets of the mitral valve, which are attached to the LV free wall with papillary muscle that we can observe here. We can see the aortic valve and appreciate that there is currently no obvious obstruction in the LV outflow tract. And you can see that the valve has these cusps with eventually leading to the ascending aorta. So this is a really good view to at least appreciate the function of your left ventricle and have a sense of already some of the major cardiac structures. And this will outline, the various structure that we just discussed. So typically when I scan, I like to do sweeps, which means that I'll do a sweep towards the posterior section of the heart. And then eventually to the anterior portions of the heart. So you can see here that So you can see here that we're going from initially, there is a posterior and then middle and then anterior view. In the posterior view, here we can see the tricuspid valve in the right atrium, and eventually we get to the RV outflow tract pulmonary valve. So if we do and use the function of the zoom, we can try to outline nicely our aortic valve. And the aortic valve, the parasternal long axis is a good view to measure the aortic valve opening at the hinge points of the attachment of the aortic valve, but also to measure the level of the aortic root and the sinotubular junction as the valve cusp connects to the ascending aorta. So here, this is an example of measurement of the aortic valve opening at the hinge point. In the context of targeted neonatal echo, there is literature looking at measurements of the cardiac output. And the measurement of the opening of the valve is one of the components of the equation in order to calculate the cross-sectional area of the aortic valve at its peak of systole when it's widely open. Now, one caveat to this particular measurement is that as you can see here, we're only measuring a diameter, and the aortic valve is not a perfect circular structure, as you will see in the parasternal short axis view module. And as such, when applying the equation, you have to keep in mind that you're not measuring a perfect circle. So when tilting your probe anteriorly, one of the most interior structure of the chest is your RV outflow tract, and your RV outflow tracts give rise to the pulmonary artery and the pulmonary valve. So this is a good view also to measure the pulmonary valvular opening at the peak of systole of the RV outflow tract. So that's another view outlining your pulmonary valve. The parasternal long axis view is also a good view to measure the left atrial on aortic ratio. So we can use the M mode, which will cut the image along the line of interrogation, and you will see time on the x-axis and the pixel movements on the y-axis as time goes along. And you can see that you have the QRS here indicating the beginning of ventricular systole, which means the moment of ventricular contraction. And so usually we do the LA on atrial ratio when you have the largest filling of your left atrium and the closure of the tip of the closure of the aortic valve. Some labs are also doing it at the beginning of the closure of the valve for the aortic valve measurement, but there's been multiple studies showing that the ratio are equivalent with both methods. And typically a ratio of 1.5 and more are is considered to be showing a discrepancy in terms of the left atrial to aortic ratio. So that could be either because your left atrium has a tendency to be dilated, such as when you have a lot of pulmonary venous return. So one cause could be when you have a large ductus arteriosus with a lot of left to right shunting. Or one of the other reason could be because you have a small aorta. So to be aware of in the context of small left-sided structures or coarctation, that you can have a ratio that would be 1.4, more than 1.4. Similarly, you can use your M mode to have a better sense of the contraction of your left ventricle. Obviously, in newborns, as you know, you have a period of transition where you have a drop in your pulmonary vascular resistances. And in the first few days of life, you might have some degree of septal flattening because of the RV and LV interaction and the increased RV afterload. And you might have also some degree of paradoxical movement of your your septum. And as such, these measurements then become difficult to interpret in terms of giving you a sense of left ventricular function. So using the M mode in the parasternal long axis view with a line of interrogation at the tip of your mitral valve, you can here see that you have your RV free wall, your RV cavity, you have your interventricular septum here, you have your LV cavity, and eventually the posterior wall of the left ventricle. And then using the M mode, there are a few specific equations that can be applied in order to have a sense of the left ventricular mass. And you can also use the M mode to calculate what we call the shortening fraction, which is basically the diameter at the end of diastole when the LV is completely filled to the diameter ratio at the peak of systole when the LV is completely contracted. And so you will find the equation of the LV shortening fraction here, which is the end diastolic diameter of the LV minus the end systolic diameter of the LV divided by the end diastolic diameter of the LV, which allows you to calculate the shortening fraction. You can also use these measurements to have a sense of the septal thickening during diastole and during systole, as well as the posterior wall. And as you know, there's a component of increased thickening as the left ventricle will contract. It is a good view to have a sense of RV outflow tract dilatation. And so you may have and perceive some sense of dilatation in the context of increased RV afterload. So once I have done a sweep in the parasternal long axis view in 2D to try to capture my overall anatomy, I then use my color box narrowed onto structures that I have an interest. So for example, in this anterior view, I can put a color box in order to see the flow through my pulmonary valve and make sure that I have flow coming from the RV outflow tract through the pulmonary valve into the main pulmonary artery. And to try to see if there's any signs of pulmonary insufficiency, such that I would see some degree of red flow whenever my valve is completely closed in systole. So the color convention tells you that if the blood flow is coming towards your probe, you would have red color, versus if your blood flow is going away from your probe, it would be a blue color. And this is just a convention that you're telling the machine. And so by convention, whenever it's coming towards you, the velocity, so the speed of blood flow, will be considered as a positive value. And whenever it's going away from the probe, you would be considered as a negative velocity. So obviously what appears here is the scale that the machine is providing you for the velocity of blood flow detected. And this scale limit, which in nomenclature might be called also Nyquist or speed velocity scale, will tell you that it will filter out measurements that are considered to be above the values of 0.79 meter per second in both directions. So obviously, if you have a high blood flow structure or high velocity blood flow structure, you might want to increase your speed limit so that you can filter out some of the lower velocity structures to really outline the flow that you're interested in. If you have a structure with low velocity blood flow, such as coronary arteries, pulmonary veins, you might want to consider decreasing the scale in order to capture the blood flow within these structures. So this is an example of a pulse wave Doppler at the tip of the pulmonary valve. So here, what do you see? So on the x-axis, you have time, and on the y-axis, you have the actual velocity. And a pulse wave Doppler will outline the velocity of blood flow exactly at the area that you're interrogating. So here you can see those two lines, and these two lines will outline that you're interrogating the blood flow at the tip of the pulmonary valve. and it will give you a sense of the velocity through time. So if you have time on the x-axis and you have velocity on the y-axis, you can do a tracing of this envelope of blood flow, which here you can see this is the time that there's ejection. And it will give you a sense of the individual distance. So for example, at time 0, you're at 0. At time 1, you will be at this amount of velocity. Time 2, you're at this amount of velocity. Time 3, et cetera, et cetera. And so doing a tracing of this curve gives you what we call the velocity time integral and provides you with an estimate of the stroke distance, which means the amount of traveling that occurred during that period of time for a PRBC sampled at the area of interrogation of interest. And so this is an example of a patient here in which we did do a pulse wave Doppler at the tip of the pulmonary valve in the parasternal long axis view. And here we did a tracing of the area that is outlined in systole. And so during the ejection phase, and you can see that the velocity time integral gives you an estimate of 0.072 meters. It can also tell you what would be the mean pressure gradient that can be derived from that. Pressure gradients are basically measured with the assumption of the Bernoulli equation that we will speak about a bit later. It tells you about the maximal velocity, which here you can also measure here. So you see that you're between -40 and -60. Minus because you're going away from the probe, so from the RV outflow tract to the pulmonary artery. And it tells you that if you're looking in centimeter per second, it is about -55, -57 centimeter per second. And then here the machine is able to tell you that the velocity maximum is -0.576 meters per second. So this is one way to look at the information from a pulse wave Doppler. And you want to make sure that you see the actual blood flow going from the RV outflow tract through the valve, and that you don't have any signs of like pulmonary atresia or pulmonary stenosis. If you have some degree of RV outflow tract obstruction or pulmonary stenosis from a valvular anomaly, you would see usually turbulence of flow, unless you have pulmonary atresia where there is absolutely no flow and the flow might be coming retrograde from a ductus arteriosus. So this is another example where we can see the nice excursion of the pulmonary valve as it opens in systole with the RV outflow tract. And then here you can see the valve with color. And then you can see that there's a tiny little kind of red fire that's coming back towards the probe. And this tells you that when you have closure of the valve, you have slightly some amount of pulmonary insufficiency, which in this case is very trivial and physiological in a sense. So the advantage of pulmonary insufficiency is that you can also apply Doppler concepts and try to have a sense of the PA to RV gradient of pressure during the diastolic phase of the cardiac cycle. Just to give you another sense of when you're looking at an echo images, you can see here that you have your area of focality, so the focus. You can see that this is the width of your interrogation for the B mode. And here you can see that this is where the probe is situated in terms of the cursor on your probe. So to go back to the idea that you can use pulmonary insufficiency jet as a way to measure the PA to RV gradient, here we're using again the concept of Doppler and line of interrogation in order to get a sense of velocity of flows. In this case, we're using the concept of continuous wave Doppler. The continuous wave Doppler compared to the pulse wave Doppler, the difference is that the Doppler interrogation will be done across the entire line of interrogation. So instead of asking the machine to provide you with velocity assessment at a narrow interrogation point, you're asking the machine to provide you with all the velocities of flows all along that line of interrogation. And what you want to do is be as aligned as possible to the actual flow of pulmonary insufficiency. So you can see that the jet is going that way and our cursor is going that way. So we have a less than 30 degrees in angulation to try to have a sense of estimates of this velocity of blood flow coming back towards the RV outflow track because it's red. So here we're doing what we call a continuous wave Doppler. And you have here the full curve of the pulmonary insufficiency jet. And basically, what does this tell you? It tells you that there's a velocity of blood flow coming back from the pulmonary artery towards the RV outflow tract. And if you actually measure, you can apply peak gradient. So you have number 1, number 2, number 3. So the peak here is measured at 4.9 meters per second, which translates into an estimate peak gradient of around 96 millimeters of mercury. How does the machine does this translation? There's an equation called the Bernoulli equation, which I'm going to open here in pulmonary hypertension and search for you Bernoulli equation. And so the simplified Bernoulli equation will tell you that the pressure difference between two cavities is equal to the 4 times the velocity square of the blood flow going from one cavity to another if the opening through which this velocity of flow occurs is a narrow point. So think of a hose and you're trying to send water through that hose and you're blocking and interrupting the end of this hose, you will have no flow. But as you're liberating the obstruction, you might have a narrow point and there's going to be pressure buildup from in the hose to the outside world. And eventually the flow will come out with a certain velocity. Pss, pss, pss. And so this velocity can be translated into a pressure gradient between the inside hose and the outside world based on the velocity at which this flow is occurring. So these concepts can be applied to some of the structures that we see in the heart. So example, if you have a leaking pulmonary valve, and there's a higher pressure in the pulmonary artery compared to the RV outflow tract, you can try to measure or estimate the pressure gradient between the main pulmonary artery and the RV outflow tract. Knowing that this occurs in diastole, it estimates PA to RV gradient in diastole when the valve is closed. And so because it is a gradient, if you want to have an absolute estimate of the measurement of the diastolic pressure in the main pulmonary artery, you have to have an estimate of the pressure in your right ventricle. We know that the right ventricle pressure during diastole is close to 0, knowing that it's a filling phase of the cardiac cycle, but it progressively rises to around 5 millimeters of mercury as it gets filled during the diastolic time of the RV cardiac cycle. And so we usually add to the pressure gradient around 0 to 5 millimeters of mercury if we assume that the RV and diastolic pressure is between 0 and 5. So in the case of this patient, you can see that you have around 96 millimeters of mercury at the peak of the pulmonary insufficiency jet. And if you look at the end of the pulmonary insufficiency jet, you get around 58, 59 to 63 millimeters of mercury of gradient, which allow you to estimate the mean pulmonary arterial pressure. So this particular patient would have about 59 to 60 to 65 millimeters of mercury of mean pulmonary arterial pressure, which is obviously very high considering that the current definition for pulmonary hypertension in patients above 3 months of age is a measurement above 20 millimeters of mercury of mean pulmonary arterial pressure. So in the parasternal long axis, I would also have a tendency to put my color box on the septum and do a scan of my septum the same way that I do a sweep from anterior to posterior in order to assess for the presence of VSD. And one thing that we don't see in these clips is to assess the apical area, which is quite important since some muscular VSD can be part of the apical area. One thing to keep in mind is that newborns have usually still a transitional physiology, and because of that, they have still high RV afterload. And so it is very easy to miss VSDs in the first few days of life because the flow through the VSD might not be at high velocity if the pressure on the RV and LV side are relatively similar. So you probably want to drop your Nyquist, so the scale of velocity, like here, you probably want to drop it to really interrogate your septum. And in a lot of cardiology labs, on the first echo, if there is, a scan that is being done to rule out VSDs, you should be scanning your ventricular septum in all the possible views with, looking at all the areas, the inlet, the outlet, the perimembranous area, as well as the apical and muscular septum. So this is just an introduction to the normal views that we see. I am hopeful that this little workshop was helpful to better understand what we see in the parasternal long axis view during neonatal life. Thank you.